Is the future of healthcare a bundle of joy or a bundle of problems? In today's video, we're diving deep into the world of bundle payments, a concept that's reshaping how we pay for medical care. But before you get too excited about this all-in-one approach to healthcare costs, buckle up. We're about to unpack some surprising challenges that come from bundling medical services. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut and I run my own medical practice. You might think bundle payments are straightforward, but trust me, there's a lot going on behind the scenes. We're going to look at everything from fuzzy bundle definitions to how this could lead to big healthcare companies taking over. Ready to untie the knots in bundle payments? Let's dive in. There are only two ways to make money: bundling and unbundling. A bundle payment is a fixed price agreement for a predefined episode of care and all related services or all care for a medical condition. Let's deconstruct this definition and consider some of the nuances. To define an episode of care, we need to consider the following: the medical problem, example, hip arthritis, with the proposed treatment plan, example, hip replacement. What constitutes an episode? That is the time during which medical care is rendered. Now, defining the time during which an episode occurs can be challenging, as we have to figure out the start and the end dates of the first and last medical event in the bundle. Let's take two examples. First is hip replacement for hip arthritis. The bundle could start on the day of the orthopedic physician's office visit, during which a decision is made for surgery. It could start on the day of hospitalization, or on the day of surgery itself, which may be different from the day of hospitalization. Then we need to define when does the hip replacement bundle end. The bundle could end on the day of hospital discharge or at a specified time after discharge, example, 1 month after discharge. The second example is a bundle for diabetes. When should the bundle start? At the onset of diagnosis or on January 1st of every year? When does the bundle end? When the patient dies or on December 31st of every year? Next, what do we mean by all care for a medical condition? To define all care, we need to figure out what medical care should be part of the predefined episode of care. Is physical therapy after hip replacement part of the all care? Is a primary care visit for hip pain part of all care because the person did not receive a call back from the orthopedic physician's office? If a person slips and falls after hip replacement while trying to get groceries and breaks the hip implant, is that part of the predefined episode of care? What about if a person slips and falls while doing physical therapy as part of recovery? Is it part of the predefined episode of care? Which medical professionals should we apply all care to? Only medical professionals working within the same business, that is, that they have the same tax ID number, example, a hospital with employed physicians, nurses, and physical therapists? Or all medical professionals involved in care, even if they work for different companies, example, an independent orthopedic surgeon that performs surgery at an affiliated hospital, then the patient receives physical therapy at a private company that is closer to their home. In this case, there are 3 different companies with 3 different tax IDs. First is the medical practice that the orthopedic surgeon is part of. Second is the hospital. And third is the physical therapy company. I'll explain later in this video the challenge of bundling payments when different companies are involved. Once a bundle is defined, then it needs to be priced. While pricing a bundle is an actuarial art in itself, here are the general rules. Calculate the average cost of all the individual services that are part of the bundle. Then add the cost of all of these services. Then adjust for geographical wage and price thresholds. For example, labor is more expensive in some areas than others. And finally, risk adjust for the complexity of patients in the bundle. And for the mathematically inclined, here's a scary looking formula on how to do a quick and dirty calculation to price the bundle. Again, a reminder that this calculation is a simplified back of the napkin calculation. Now that we understand what a bundle payment is and how it is priced, we'll look at the problems it causes. But before that, let's take a very brief detour and look at the history of bundle payments and how we got here. In 1983, CMS, which administers Medicare, introduced the diagnosis-related group as a bundle to pay hospitals. Instead of paying hospitals a la carte, Medicare classified hospital cases into 500 groups with the expectation that patients within each group would need similar resources. For example, all patients admitted with pneumonia would, in theory, need similar services. Under the DRG system, hospitals were paid a flat rate per case for inpatient hospital care to incentivize hospitals to control the cost of hospitalization. In 1991, CMS experimented with a coronary artery bypass bundle, or a cabbage bundle, that included hospital and physician services, but then they abandoned it. I have not found any information on why CMS abandoned the cabbage bundle, but my suspicion is that it was due to hospitals and surgeons being in different tax IDs. That is, they were working for different businesses. Since then, CMS has experimented and continues to experiment with several different bundles as part of the Affordable Care Act and MACRA. However, there's mixed evidence of whether CMS saved any money from any of these newer bundles, especially when you account for the complexity of administering the bundle. Private insurance companies, especially Medicare Advantage, have followed CMS's footsteps in creating bundles. Most of these bundles are for surgical procedures such as hip and knee replacement, but some insurances also have bundles for pregnancy care. With this background, let's turn our attention to the problems created by bundle payments. While the bundle for a surgical procedure is more easily defined, it becomes more challenging to define a bundle for chronic diseases. Let's try to construct a bundle to manage and pay providers to take care of diabetes. Using the definition we discussed earlier, we first need to define the episode of care for diabetes. We could define the time period as 1 year, that is, from January 1st to December 31st. Next, what medical care is part of this predefined episode? It seems reasonable to include diabetes-related office visits, urgent care, and hospitalization. But then how do you differentiate between an office visit for diabetes versus a more comprehensive visit in which multiple medical problems were addressed in the same visit, which is a big chunk of primary care visits? What about labs ordered for diabetes? You could easily game the system by ordering most of the labs under different diagnoses, for example under hypertension. Should we include diabetes medications in this cost? Again, this can be gamed as some medications can be used for different medical problems. For example, lisinopril is used both for hypertension and for diabetic kidney disease. Atorvastatin or Lipitor is used both for high cholesterol and also in diabetes. And then which medical professionals should we apply this to? Endocrinologists, who's prescribing the main diabetes medications? What about primary care doctor who's prescribing medications for diabetic kidney disease and atorvastatin to reduce heart disease? And what about a podiatrist or ophthalmologist who does a diabetic foot exam or a diabetic eye exam? The next problem is gaming risk adjustment. Remember the complicated equation on how to calculate the bundle price? You can increase the price of the bundle by making people look sicker. If you want to understand the art of making people look sicker, you need to watch my previous video on risk adjustment in value-based care. The next problem is unbundling the bundle. This involves removing reimbursable codes that would generally be part of the bundle. There are several ways to do it, but I'm aware of two common methods that are used. Provide the same treatment under a different ICD-10 disease code. For example, prescribe lisinopril under the hypertension ICD-10 code instead of diabetes with kidney disease. Claim pre-existing disease to make the argument that it should not be part of the bundle. Why do you think most people get a urine analysis when admitted to the hospital? If the urine on admission is dirty or shows bacteria, the hospital can claim a higher DRG as there's a pre-existing condition of urinary tract infection. Just so that you know, many of these urine samples that are dirty, they're due to collection technique and do not need any treatment. What happens when a patient switches either providers or insurance plans that are not part of the bundle? This can happen in three ways. The first is that the patient has a new provider but is in the same bundle. This can happen when the patient moves to another city or state and establishes care with new providers who are part of the same bundle, but the insurance plan does not change. Example, a large national employer plan where the employee was transferred to a different location. How is the bundle payment split between providers in these different states? Next, the patient has the same provider but now is with a different insurance company. This can happen when the patient switches insurance plans. How will the insurance reimburse the provider for the care that was already rendered, especially if the insurance pays out once a year or at the end of the bundle? My wife and I were caught in this exact scenario as we were in a pregnancy care bundle and we switched insurance plans. The insurance refused to pay the obstetrician's office and their office transferred the entire bill amounting to several $1,000s to us. After several calls to the obstetrician's office and the insurance company, I finally figured out that the insurance company was refusing to pay the OB office as the pregnancy care cycle was not complete according to their records, even though they knew that we were no longer enrolled in their insurance plan. After much back and forth with me explaining how bundle payments work to the insurance agents, I was finally able to resolve the issue. Last is when the patient switches both insurance plans and providers. In this case, the provider may be left fighting the insurance for reimbursement, which, if denied, will be a much higher amount than it was for the individual service. This unpaid bill may then be transferred to the patient. The insurance company wins as they don't have to pay anything, while both patients and doctors lose. A bundle payment is easier to administer when all the healthcare entities are under the same business umbrella, that is the same tax ID, so that reimbursement is sent to one place. However, when different healthcare entities under different tax IDs are involved, then who receives the payment and how will it be distributed to all the involved parties? For example, in a hip replacement bundle, several healthcare entities may be involved. These entities may include an orthopedic surgeon, anesthesiologist, primary care physician, hospital with an employed staff, skilled nursing facility, and outpatient physical therapist. Let's take a look at a process workflow for hip replacement and then try to apply bundle payment to this workflow. A patient visits his PCP for hip pain. The PCP refers the patient to an orthopedic physician for evaluation as conservative measures such as physical therapy have failed. The orthopedic physician determines that this patient needs a hip replacement and sends the patient back to the primary care physician for a pre-op evaluation. After that, the patient is admitted to the hospital, and then the patient is scheduled for surgery with the orthopedic physician and the anesthesiologist. After the surgery, the patient is discharged to a skilled nursing facility. The orthopedic physician is also involved in the outpatient postoperative care, and the patient is also receiving outpatient physical therapy. This is a typical workflow for hip replacement with some variations. For example, the patient may be discharged home instead of a skilled nursing facility. A typical hip replacement bundle would be limited to hospital services, since the hospital is the largest business entity and generally is the one that negotiates the bundle. So the hospital gets paid for the bundle payment for the hip replacement surgery. But in this case, the anesthesiologist and the orthopedic surgeon, who are not part of the bundle, get paid separately for their services related to administering anesthesia, performing surgery, and postoperative care while the patient is still in the hospital. If we continue to expand this bundle to now include the outpatient office visits by the orthopedic surgeon when the decision is made to perform surgery, and also for postoperative care when the patient is discharged, then how is the orthopedic physician reimbursed in this bundle? If we now also include the pre-op evaluation done by the primary care physician, then how is the PCP paid for in this bundle? Also, if there is a complication and the total cost of care increases, then who bears the burden of this higher cost? The central concept of a bundle payment is that it tries to tie together all the services provided by different businesses so that they will hopefully come together to figure out how to become more efficient and save money. However, in this case, the insurance plan will only negotiate with one healthcare entity to set the price of the bundle, which generally will be the largest business entity in the bundle. And in most cases, this is the hospital system. This large hospital system will keep its portion of the money in the bundle, and then the rest will be distributed to all the other healthcare entities that provided medical services that were part of the bundle. This then creates tension between the large hospital systems and the smaller medical businesses such as doctor's office, skilled nursing facility, or the physical therapist, because everyone wants a larger portion of the bundle. If these smaller practices negotiate a higher rate, then the large hospital system gets very upset as its pie gets smaller. That is, its profits shrink. To increase the profits, the hospital system has two options: negotiate a higher bundle rate so that it can keep more of the profits, or buy all the entities so that they can keep the entire pie. And after buying all of these entities, the hospital system is even bigger and with more negotiating power. Now these large systems can not only keep the entire bundle payment, but they can also use their negotiating power over the insurance company to increase the size of the bundle. Remember large organizations' excuse for mergers? It brings economies of scale by simplifying operations. Well, this is an example. Untangling overlapping bundles. Let's take the example of two health entities, the Accountable Care Organization or ACO and the hospital. Both the ACO and the hospital have their negotiated bundle payments with different reimbursement rates. The hospital has operating room facility, nurses, and technicians. The ACO has independent providers such as orthopedic physicians, anesthesiologists, primary care, and physical therapists. If a patient needs surgery at the hospital, this can create problems if the surgeons, anesthesiologists, and primary care physician are part of the ACO. Which bundle rate is used for payment? The hospital negotiated rate or the ACO negotiated rate? Which entity receives the bundle payment, the hospital system or the ACO, and how's that going to get distributed? This can get complicated quickly if there are multiple health entities, each with its own negotiated bundle. The easiest way out of this mess is to own all the entities under one single umbrella, that is, to consolidate. Going back to what I said before, The central concept of a bundle payment is that it tries to tie together all the services provided by different businesses so that they will hopefully come together to figure out how to become more efficient and save money. In other words, bundle payments will lead to centers of excellence. However, the downside of these bundle payments is that they are much more likely to lead to consolidation, which in turn will lead to higher prices, not just for bundles, but for all services. This will not only diminish any healthcare savings in bundle payments, but in the long term, bundle payments will increase the total cost of care. You can find a written version with references to this material that I discussed in this video on pcplens.com. You can also find an audio podcast version of this video on pcplens.com. If you're watching on YouTube, please like and subscribe. This helps me find a wider audience and spread the message. By the way, if you thought that value-based care increases the quality of care that you receive, then you need to watch my next video on how these quality metrics may actually be hurting you. Please sign up on pcplens.com so that you don't miss my next video when it is published. Thank you for watching my video. Take care and goodbye.